Ambulatory phlebectomy is a useful component in the comprehensive treatment of patients with varicose veins. When compared with sclerotherapy of bulging veins, ambulatory phlebectomy is more effective and gives a better cosmetic result. A carefully performed ambulatory phlebectomy can remove virtually 100% of all varicose veins and leave little or no scar. When a well-done phlebectomy is performed in patients with C2 or C3 disease, the underlying great saphenous vein, which is frequently dilated and incompetent, can return to normal size and function. The gold standard for phlebectomy is the one used by Drs. Paul Pitaluga and Sylvain Chastanet in performance of their ASVAL technique at the Riviera Vein Institute. I had the privilege of spending time at the Institute to learn the ASVAL technique firsthand. I learned the important principles which make this technique efficient, virtually scar-free, and powerful enough to restore a failing great saphenous vein to normal. Last November, Dr. Chastanet presented a video of the ASVAL technique at the VEITH Vascular Symposium in New York. At that same symposium, Dr. Pitaluga presented a 10-year summary of their experience with the ASVAL technique. These presentations can be viewed by going to the VEITH Vascular Symposium on-demand website. Despite their presentation of this beautiful and effective technique, the ASVAL procedure is not frequently performed by American phlebologists. In order to make this technique more user-friendly and perhaps increase its popularity in America, I have developed a modification of their technique which I call Easy ASVAL. The essential difference in my technique is that I use acupuncture needles to pin the varicose veins in place prior to infusion of tumescent anesthesia. To date, I have done over 400 of these procedures and have achieved similar results to those published by Drs. Pitaluga and Chastanet. Because the acupuncture needles make it virtually foolproof to locate the varicosities, I have been able to teach this technique to non-surgeons as well as paramedical personnel such as physician's assistants and nurse practitioners. The results they have achieved after learning the technique have been quite excellent. My hope is that this video will serve as a kind of skeleton key to clarify the important details of this technique for American phlebologists, and that this will help to increase its use here in the United States. The Easy ASVAL procedure is being performed on a healthy 46-year-old female patient who has a large, painful, unsightly vein along the anterior lateral branch of the great saphenous vein. This tracks along the proximal thigh and down the distal lateral thigh and proximal calf. The proximal 15 centimeters of the right great saphenous vein, which feeds the anterior lateral branch, is enlarged at 6.2 millimeters and incompetent from the saphenofemoral junction to the takeoff of the anterior lateral branch. Distal to this portion, the great saphenous vein is normal. A loop of the duplex scan shows the large, incompetent great saphenous vein as described above. The patient is brought into the operating room in the standing position and a tourniquet is applied to the right lower extremity just above the groin crease. The patient exercises for a few minutes until the varicose veins become distended and quite obvious. The patient is then placed in the supine position and the leg is prepped and draped in the usual sterile fashion using chlorhexidine prep. Once the right lower extremity is prepped and draped with the patient in the supine position, the patient is placed in reverse Trendelenburg at approximately 60 degrees. The distended varicose veins are visualized with a sterile transilluminator and pinned in place approximately every 6 centimeters with number 8 serine acupuncture needles. The patient is then placed back in the supine position and the proximal tourniquet removed. After a small wheel of local anesthesia is placed at the base of the acupuncture needle, a generous amount of tumescent anesthesia is placed in the subcutaneous tissue using an infusion pump until peau d'orange develops in the overlying dermis. This ensures that the varicose vein has been adequately exsanguinated and hydrodissected by the tumescent fluid. The excipient used for the tumescent anesthesia is isotonic sodium bicarbonate rather than normal saline or Ringer's lactate. The isotonic sodium bicarbonate potentiates the effect of the lidocaine and therefore makes all subsequent needle punctures in the subcutaneously infused tissue completely painless. Therefore, except for the initial wheel, the procedure is entirely pain-free. This means that the entire phlebectomy is less painful than a typical sclerotherapy session. It is essential to use some form of magnification to perform this procedure precisely. Surgical loupes are the ideal tool for this task. However, if these prove too costly to purchase, inexpensive magnifying lenses can be purchased to substitute for vascular loupes. This shows the typical easy ASVAL maneuver. The skin is punctured a few millimeters from the acupuncture needle at 45 degrees to the skin. Both sides of the acupuncture needle are targeted with the bevel of the 16-gauge needle through the same insertion site. A small skin flap is made upon removal of the needle. My preference is to use a 1.25 millimeter Susan Bates crochet hook to enter the puncture hole. Once the acupuncture needle is contacted, the hook is rotated 90 degrees toward the surface of the skin and the acupuncture needle removed, and the crochet hook usually catches the underlying vein on the first or second pass. If the vein is not large enough and strong enough to be removed in one piece, the acupuncture needles are very helpful in making sure that the entire vein has been removed, even if it has to be done in pieces. This shows that a previously measured 3 millimeter varicose vein now has a diameter of less than 1 millimeter after being surrounded by generous amounts of tumescent anesthesia. In moderate to large size veins, there is enough structural integrity in the vein that it can frequently be removed in one piece. In this setting, it is helpful to keep tension on the vein at all times with the phlebectomy hook while gently removing the vein with a small curved clamp. In general, the smaller the varicose veins are, the more difficult it is to perform an effective phlebectomy. One major advantage of using acupuncture needles is that one can effectively remove varicosities as small as 1 millimeter, since they remain pinned in place during placement of the tumescent anesthesia and are quite easy to locate and remove completely with the help of the acupuncture needle. This shows the end of the varicose vein being tied off rather than being avulsed from its connection to a deeper vein. This limits ecchymosis and probably helps return the underlying saphenous vein to normal size and function. This shows the patient walking normally within 5 minutes of completion of the procedure. This entire procedure was done under straight local anesthesia. There was no intravenous sedation given. This is a postoperative duplex scan of the patient's proximal right great saphenous vein, showing that within 1 week it has returned to a normal size of 4 millimeters and shows no evidence of reflux. The patient was totally asymptomatic at the time of her first postoperative visit.